Dr. Sachin, just click on the email tab.
Yeah, yeah. थोड़ा स्लो हो गया हूँ, ओपन करे वाला वो मोबाइल पे था। Guys, this is our case mate 39, and we are with us our stalwart Dr. Hemant Shinde sir. He will speak on difficult airway in obstetrics. He is our Nisa News editor, one of the best person in our ISA chapter. He is practicing in Mumbai since 30 years. Basically, his areas of interest are bariatric surgeries, difficult airways, and thoracic surgery, which are in fact from really we found of that cases, that how sir did these cases in their practice. He is having very vast experience of private practice, as actually almost 30 years he did uh, freelancing in the corporate hospitals. So, welcome you, sir, on this platform of our ISA Nanded, and this is our like flame of unity, like that. We are running marathon since first case meet to now. We came to 39, and it will be, I hope, will complete 75 years. So it will be tribute to our ISA Nationals 75 years.
Absolutely.
So we are like that. With that, our 25th years of our silver jubilee year of our ISA city branch also. So we are conducting this case meets regularly. So our main motto to of this case meets is in very heavy practicing persons not able to connect with academics, and that too in even on online or offline. So I also added in this, we upload all recorded version of this case meets to on our ISA YouTube channel, so anybody can see in his free time whenever he is free, as our anesthesiologist life is so pretty difficult that you don't know what time you will be free. Sir has delivered almost 200 plus lectures nationally and internationally also. So one of the really hats off to you that you came on our platform.
Always happy to teach. Yeah, I love teaching.
Thank you, sir.
You can hear me, no?
Yes, sir.
You are able to hear me?
Yes, clearly.
And you can see me also.
Yeah, definitely.
Fine. So once your screen is active, we'll go.
Yeah, within 1 minute, sir. Just. Due to some technical glitches, today's viewer will get some extra benefit always with this. Lot of recorded versions are downloaded in this laptop, so it is running slow.
Yeah, I understand.
I will try to delete, but they are so pretty resolutive. You don't want to delete them. I
Yeah.
actually upload on YouTube also, but somehow I'm not feeling that I should delete this recorded.
Then you will have to take them in the another
Yeah,
drive.
pen drive like that.
Yeah.
I'm trying that.
In a bigger hard disk, because if it is in a
Yes,
huge presentation, then it's difficult to.
yes. Every presentation almost to 1 hour to 1.5 or so.
Yeah. So it's a big one. It's a big one. And these are all important topics we must discuss to the best of our abilities. I have very fond memories of coming to Nanded.
In 2017.
Yeah. I mean,
That
lovely,
time,
lovely
I was a
conditions.
treasurer, but actually I fall in at my home. I fall, so I got fracture.
Oh
Deep.
my God.
Yeah, so not able to join whole session, or almost half conference was not possible arranged by me, or activities in conference also.
Yeah. But it was beautiful. We enjoyed thoroughly.
Yes.
Yeah, now it is coming.
So I will start slideshow
Yeah.
from beginning.
Yeah, from this slide only.
Yes. Here, what is? So is it okay?
Yeah, I can see. Only thing is to forward, I'll have to ask you, right?
Yeah, definitely. No problem. I will do.
Yeah. So these initial slides, of course, will go right. Everybody knows I am from Mumbai, and we are going to discuss difficult airway in obstetrics. So next. Next Ladana, Sachin, next.
Yes. Yeah.
So this is what we are going to discuss. चालू करूया का रे?
Yes. बिल्कुल मी आता introduction दिलंय,
हा चालेल मग
but
चालू.
still yeah, recorded is starting.
Okay.
So once again, should I
No.
introduce?
We'll go. You have
Yes.
already Yeah.
Yeah. Okay,
So
sir.
this is what we are going to discuss in next whatever time, about 40-45 minutes. There will be some definitions I'll discuss. Then, of course, why the incidence of difficult intubation in the obstetrics is on the rise. What's the role of obesity in it? How do we assess the difficult airway? We will discuss that also. Next, please.
Sorry, sir.
Yeah. And then we will also see talk about some of the gadgets. How do we manage the algorithms when we have a known difficult airway or a unknown difficult airway? The algorithms are different. Is the extubation important? That's another question we will try to answer. And finally, we'll have conclusions, take home messages, and obviously, I expect all of you to ask questions, comments. So we start. Next one, please. So, what is a difficult airway? In obstetrics, we want to say. So, whenever we intubate a patient, if you are doing a general anesthesia, cesarean section, or for that matter, any case, what is our idea? That is, we want to provide adequate oxygenation. That's one part of it. And second part, obviously, is the prevention of aspiration. Because oxygenation you can supply even with a mask, but then aspiration you cannot prevent with a mask. And that is why we always try to intubate a patient. So whenever we are giving general anesthesia to a cesarean, or for that matter, any patient, these are the two main aims, is that to give adequate oxygen and prevent aspiration. Then, of course, manage the depth, control the ventilation, CO2 management, all that comes. But the essential part of any intubation is oxygenation, prevention of hypoxia, prevention of aspiration. That is the whole game. So, what is a difficult airway? Now, when you can't assure any of these, either oxygenation or prevent aspiration, that is a difficult airway. And invariably, it lands you into, I mean, your patient into hypoxia. Next. Then we will discuss what is impossible mask ventilation. Now, that is inability to provide positive pressure ventilation by doing all these things. So, what are we doing here? We are repositioning of the head and neck. We are doing anterior jaw lift of the patient. We put in an oral airway, put in a nasal airway. We ask another person to help us and try to ventilate such patient. But despite that, when you cannot ventilate a patient, that is called an impossible mask ventilation. Next. Sachin, next.
Yeah, I'm trying, sir.
Then what is a difficult LMA ventilation? Now, LMA has come into almost all the difficult airway guidelines, and that is our second line of defense. If your tube is not going, we must try to use an LMA. But again, what is a difficult LMA ventilation? That is when inability within 3 attempts of device insertion. You tried 3 times inserting an LMA and it is not going. You are unable to give 7 ml per kg of tidal volume. Your leak pressures are less. You cannot ventilate a patient despite putting an LMA. That is a difficult LMA ventilation. Next, please. So, how do you define difficult intubation? That is another thing we must know. Coming to the definition is, it is defined by when you do all these things, like alterations in management associated with failure to secure a successful ET tube. That means your tube is not going despite you trying all these stunts. Like you change the position, you use different laryngoscopy blades, you use ask help, your help also tries to do the intubation. So more than one experienced anesthetists are trying to intubate a patient, and despite all this, you trying your external maneuvers, you are pressing the larynx, you are changing the position, nothing is working. And that is the time you say that my it is a very very difficult intubation that is this patient is having. Next, please. So, what is the incidence? Now, this has always been told to us that we have invited this problem onto us. So, you will wonder why. How come we have invited this problem onto us? Now, I can always, whenever I'm in a live meeting, I always ask uh, by show of hands that how many of you have recently done a general anesthesia cesarean section as compared to a regional anesthesia cesarean section? And most of the anesthetists lift up their hands that regional they have done maybe today, maybe yesterday night or what. In my case, today also I have done, yesterday night I did one, yesterday morning, and both were regional anesthesia. As compared to if you ask me when was the last general anesthesia section I did, I don't even remember. It must be pre-COVID. So it's almost 2 to 3 years I have not put in a tube in a cesarean section, and all the cesareans have been under regional anesthesia. So you will understand where I'm getting. Most of the anesthetists are doing regional anesthesia, spinal, epidural for cesarean sections. So our training in general anesthesia for cesarean section is taking a backseat. If I haven't done enough, how my residents in a teaching institute are going to do adequately? So that is what is happening worldwide. So the incidence is increasing. It's one in almost 400. The recent literature, which I will show you, the incidence has come down significantly. It is now more common. It is now in some of the countries, it is one in 150. Some of the countries, it is one in 225. So, and that is what is happening. This paper was written way back in 2007, 15 years ago. And what did they say? Incidence is likely to increase. And that's exactly what has happened. One in 400 is now becoming one in 200. In some of the countries, it is one in 150. Now, this is because, like I said, we have invited this problem because most of us are doing regional anesthesia section. Our experience in GA is taking a backseat. Since you don't do these things, suddenly when you are forced to do something, you are likely to make a mistake. So there are limited opportunity to teach and practice the skills that are necessary to obstetric airway management. And that is where the problem is. And on top of it, the obesity is increasing. Any obese patient, I'm sure all of you know, it's difficult to intubate, difficult to ventilate. And in such patients, when you try to do suddenly an intubation in a CAT, you will have issues. So next, please. Now, failed tracheal intubation during obstetric general anesthesia literature review, we'll just see the evidence. Now, maternal mortality from failed intubation is 2.3 in 1 lakh in GA for section. Maternal deaths are mainly because of aspiration or hypoxia, like I said in my first slide. And most of the cases, they have found out that anesthetists who are managing these cases are extremely reluctant to go in for a cricothyrotomy or a tracheostomy. And whenever it was attended, it was always very late by the time the patient had become hypoxic, and patients with then the rescue become very poor, and invariably patient landed with cerebral hypoxia or even death. Next, please. Maternal mortality and morbidity. This is another paper which discusses why mothers die. And it was just a 2 years study. And see, the leading cause of anesthesia related mortality were airway complication, and GA has greater morbidity than regional. And that is why we all, the moment somebody tells me you got to do a section, the first thing that comes to my mind is, oh, I'm going to give regional. Unless and until I'm forced to give GA for some reason, I don't give GA. And I'm sure most of us are doing the same thing, and the world evidence is also saying the same thing. Next, please. So how common is this fatal failed intubation? Now it is 8 times more common than the surgical patient. So you have an surgical patient, appendix, or lap chole or a laparotomy. Compare that to an obstetric patient who's pregnant, 8 times you have more chances that you will have a difficult. That's very, very significant. So when you have a GA section, you got to be very, very alert. And especially so in an emergency cesarean delivery. It's all the more difficult in an emergency cesarean section. Next, please. Now, is obesity significant? We will see. Anesthesia complication. Now, this was another paper where they tried to see if obesity has any relevance. And this was done, of course, in United States of America and from a period in Michigan from 72 to 84. Okay, in a 12-hour year study, they found 15 cases. Primary cause was anesthesia related death. 12 were obese, so 80% were obese, and 10 cases emergency surgery, that was again 80%. So emergency case cesarean section in an obese patient, you got to be very, very careful. Next, please. Now, again, to answer this question, they did the study after first study we saw 72 to 84. This study they did from 85 to 2003, another 18 years study. In this, you will see the number. It was 15 deaths. Here it is only 8 deaths. So number has come down significantly. But 6 are obese. So obesity still remains the problem. And this time, it occurred during emergence and recovery due to hypoventilation and obstruction. That time it was intubation problem. We've, I think, grown over our intubation difficulties because we've got gadgets, we've got video laryngoscopes, we've got LMAs. So we are better off while intubating. The problem is with extubation. This time patients died because of hypoventilation and obstruction while coming out of anesthesia. So this is another important study. This is 2021 study, okay? Last year's study. Now this is from Saudi Arabia. Now I'll tell you one thing. Saudi Arabia and in entire Gulf, lot of sections are done under general anesthesia as compared to Europe, America, Asia. You will see this, look at this, what this paper says. This is last year's 2021 gynecological journal. GA was used in, see, 10,000 cases. Imagine 10,275 cesareans. 51% of them have undergone GA. And about 10 minutes back, I told you I have done my GA section 3 years ago. So look at the amount of GA sections that are happening in Saudi Arabia. 42 documented difficult airway. That's 0.8% incidence. Incidence ratio is 1:125. I told you first slide 1 in 400. Now it's become 1 in 125. Very, very common. What are the things? Same paper again. Failed intubation occurred in almost 60% of cases. And out of this 60%, 42% had difficult airway. Next, please. CS was in 55% of cases emergency. Mean age of the patient was 33 plus minus 5. So you can say 27 to 38. Weight was 60 to 163 kilos. That's significant. 60 is quite a normal patient. 163 is huge. And over 58%, so 60% almost weighed more than 90 kilos. I mean, Indians are that way not very obese. We are catching fast with obesity. 90 kilo patients these days are pretty common in my practice also. I've done max around 140, 145 in an obstetric case, not 163 as this study says. Next, please. And last slide on this particular paper, 50% of cases airway were rescued with LMA. So your LMA becomes your important defense. 50% reintubation succeeded. And fortunately, in this study, outcome was good for mother and fetus in all the cases. That is something is very, very reassuring. They were doing more GA cases, more difficult intubation cases in obese patient, in emergency. They had problems. They survived with LME and intubation. But thankfully, the mother and the child both survived. That's a really, really, really great. Why obese are at increased risk? Let's see. Because see, first of all, right in the obesity, the from problem starts even from pregnancy. So getting conception in an obese patient is a problem. Sometimes they come for a lot of other things to you, like ovum pickups, then the ovum insertion, then they come for precious pregnancy. They've got lots of systemic diseases. It involves right from your top to bottom, every system is affected. Everywhere there is fat, so there is difficult airway, blood pressure, diabetes, central obesity, no neck. So all sorts of these things are happening in an obese patient. You try to give a spinal or a neuraxial anesthesia, getting neuraxial anesthesia also is a difficult. Chances of failing such neuraxial anesthesia are very high in obese patient. And that is why when they land up in an emergency and all these things happen, you have to end up giving them a general anesthesia. Please. So why obese are at increased risk? Then when you start giving them anesthesia, chances are that the position may be difficult. The required pressure, the person who's applying may make it into a difficult intubation. The breasts are huge in these patients, so micromastia, that can sometimes cause problem for your laryngeal blade. Physiologically difficult airway. What I mean by this is there are two lives in a mother, her own as well as her baby's. So oxygen carrying capacity in pregnancy, FRC has gone down. The uterus is pressing it from lungs and diaphragm from below. So the FRC goes down. The oxygen consumption increases. So they become a physiologically difficult airway. That means they require more oxygen per minute than a non-pregnant patient. And that is why the chance of getting them hypoxic as compared to a non-pregnant lady are much, much higher. And that is why they are physiologically difficult airway, in addition to an anatomically difficult airway. And then when you know that I have an emergency case where the patient is not fasting or fasting, whichever way, is obese, has a fetal distress, you're working in not so great setup in the middle of the night with no help around. Now you can imagine what all can go wrong. Next, please. So American Society of Anesthesiologists is the closed claims. That means closed claims means settlement was done either by hospital or whichever way. But then they open these cases and analyze to learn from them, not to gossip around, but to learn from them. And what did they find? Most of the cases were substandard management. Means our planning was pathetic. We had inadequate ventilation, esophageal intubations, difficult intubation was not what you say anticipated before. So you tried to give general anesthesia and then they could not intubate and the setup was not so great and they landed up in big, big, big problems. So this is for us to learn. What is the incidence of difficult intubation? Now in different countries, different seniority, different experience, it keeps on varying. But frequently unexpected, usually difficult intubations. It's around 8% in some studies. More than 3 times the incidence witnessed in the non-obstetric population. In the another few slides back, you saw 8 times more in non-obstetrics cases. According to this paper, it is more than 3 times. Whether 3, whether 8, but still far higher. Then this study was done by Sachin Khetrapal. 22,000 attempts at mask ventilation were seen and impossible ventilation was found in say 0.3 or 0.4% of cases. Please. This another study showed it was 15.5%. So like I said, it depends on the country to country experience, whether you're working in what sort of setup. So the real incidence in India may be in between somewhere. It may not be as high as 15, but it may be somewhere. And what are the risk factors for this airway complications during pregnancy? There are so many which I have enumerated, like airway edema, FRC goes down, I told you, oxygen consumption is more, weight gain occurs, the breasts are huge. So these are physiological changes that are happening in the lady, which itself is causing complications. Then, of course, then there are more additional like bull neck, large breast, large floppy epiglottis, large tongue, and then there are, then the next slide, please. Then there are other syndromes like Down syndrome, Klippel-Feil, all these Ludwig's angina things are up. So there are multiple factors that are involved. So remember this, your airway assessment has to be good. But what is the reality? See this prospective study, 1,200 patients, 51% of the difficult intubations were completely were anticipated, that means 49% were missed. So it's almost 50-50. Out of the two, one is missed. So do your airway assessment very, very properly. Do your limon. What is your limon? Look externally, evaluate 332 rules, that your mouth opening is 3 fingers, your hyoid to chin distance is 3 fingers breadth, thyroid cartilage to floor mouth is 2 fingers breadth. Malampati, everybody knows 1, 2, 3, 4 gradations. Your, is there any obvious obstruction, and your neck mobility. Malampati we know, but remember, just doing only one single study of Malampatti is not helpful at all. It is good. It has 91%, 98% specificity, 80% sensitivity. Next, please. So a multifactorial index will always help you, like this. See, you are doing your Malampatti, find out whether it is 2, 3, or 4. But find out if the patient has short neck, receding mandible, protruding maxillary incisor teeth. That also are risk factors which are associated with difficult intubation. So I'm in the pictorial format, I have given you about 7 of them. So what is your mouth opening, thyromental distance, neck movement, mandibular protrusion, or your body weight, Malampatti classification, and presence of difficult intubation history in the past. So instead of doing just one study, do these all 7, and they are superior to your Malampatti. Okay. So the same thing is given here. In a British study, they found that age, as it increases, so a primary gravida coming at elderly primary, 40, 45, which is again obese, with a higher Malampatti score, definite independent risk factor for difficult intubations. Now, these are same thing in the pictorial format. Ask them to do the bite test. There are again problem. Your lower mandible is not coming ahead. Your atlanto-occipital joint extension, if it is reduced, that also becomes a difficult intubation. Please. Then again, your thyromental distance normal is 6.5 centimeters. If it goes down to less than 6 centimeters, then you have a problem. Your mandibular protrusion test, I told you, upper lip bite test. If your patient can't do this, that means there's a problem. And morbid obesity, again and again, I'm telling you, difficult intubation occurred in 35% of morbidly obese patients. 300 pounds is about 130, 140 kilos. In India, we have started getting 140 kilo patients. I have done a few of my own. So chances are that if you are ending up giving GA to these patients, you will have difficulty either in ventilation or in intubation. Preeclampsia is another headache. Now, these patients have got lots of extravascular fluid. Their oncotic pressure is low. They have got low platelets. They tend to bleed more, and repeated attempts of intubation can lead to airway edema, glottic edema. So how do you prepare when you want to give general anesthesia? To the previous one, please. How do you prepare when you give? Now, there is an aspiration prophylaxis. Unfortunately, sodium citrate, which was available in India, is no more available in India. One company was making it, not adequate sales, so they decided to stop it. Ranitidine is sometimes available in few places where I work, otherwise it is again banned injection format. So now we have only Perinom, Pan 40. So whatever is available, please give to the patient. The next thing you can do is, if you are in a good setup where you have an ultrasound, just put it on the stomach and check how much is the volume. You can definitely see a full stomach or an empty stomach, which will give you a lot of reassurance. If it is an empty stomach, you're happy to know that, okay, at least the patient will not aspirate. Please. Then positioning in an obese patient, again and again, it has to be a ramp position. Everybody knows about it. The functional residual capacity increases. Now there is something known as 8. You see, normally when we do pre-oxygenation, what we do is tidal breathing. We keep a mask, 10 liters of oxygen, ask the patient to take deep breaths, and by the clock 3 minutes if we wait, or end tidal O2 if you are monitoring, and if it comes to 90, that is the end point of your oxygenation. Then you give your induction agents, and then you give your muscle relaxant and try to put in a tube. But previous slide, please. 8 different 8 dB is a different concept. Suppose you are into an extreme emergency where your surgeon is washed up, he doesn't want you to wait for 3 minutes. Now, what you are going to do? So, there is a method by which you ask the patient to take 8 deep breaths in 1 minute, and it gives similar oxygenation as what you would have got in after 3 minutes of tidal breathing. So, if you don't have time to wait for 3 minutes, you have 1 minute. Ask your patient to take 8 deep breaths, you will get the same oxygenation. So then, next slide, please. Somebody went in for 4 breaths. People are smart. If you have only 1 minute, now they want to cut down to 30 seconds. So somebody tried 30 seconds, 4 deep breaths. What was the oxygenation? And it wasn't satisfactory. So if you don't have time, 1 minute, 8 deep breaths. Thrive is again another beautiful thing. 70 liters of oxygen goes per minute. Put it into the nose of the patient. It is very, very humidified, so it doesn't trouble the patient at all. It will cause apnic oxygenation, and your patient will not have hypoxia. Hypercarbia will occur, but patient will not die of hypoxia. If the only take home message you want to take home from this lecture, which I'm giving for the Nanded guys, I would like to tell you, at least have a difficult airway cart made in whichever hospital you are practicing. This is how it is made: different blades, different airways, different laryngoscopes, oral airways, nasal airways, handles, everything kept in a single trolley with tubes, LMAs, fiber optic. If you have, put it over there. It has to have wheels so that it can be taken to the ward, to the OT, to the labor room, to the wherever you want to take it. And if you have working in a multi-storied hospital, then you should have many of such things so that a life can be saved. At least one take home message: if you have a video laryngoscope, it is another beautiful line of defense. Next, please. I myself, most of the hospitals where I use CMAC because that is the one they have provided me with. What it does is, look at it. This is May to 2015, about 5 7 years. The usage became rampant everywhere, and they have found it improves the glottic visualization. The speed increases quickly. It intubates. Difficult incidents come down. Morbidly obese patients, it is my first choice. I don't intubate with a normal laryngoscope. I go in with a video laryngoscope. So if you have video laryngoscope, then you must go with a proper position, give a ramped up position, oxygenate. Whether 3 minutes, 1 minute is immaterial. Propofol or pentothal, immaterial. Scoline or long acting, immaterial. As long as you are very sure what you are going to do, go for it and use your video laryngoscope and put in your tube. That's how. In an anticipated difficult airway, I would like to say, on the left hand side, whatever is given is avoid airway manipulation. And that is what you must do. Spinal, regional, epidural, combined spinal, epidural, or combined spinal, or continuous spinal. That's it. Whether it is labor, whether it is cesarean section, emergency, elective, you set your mind in such a way that I am going to give only regional. And if your first spinal fails, if it's there is still time, make the patient sit and give another spinal after 20 25 minutes. But if, God forbid, you decide to accept airway manipulation, you want to go in for GA, then prepare yourself well, get some help, have it in the proper setup in a tertiary care hospital with adequate help, ward boys, nurses, colleagues, with all your difficult airway cart ready with you, different blades, video laryngoscopy, and then try and do an awake laryngoscopy. Try and see if you can, it's well and good. Otherwise, go in for regional anesthesia. But what happens when it is unanticipated? The problem starts with unanticipated. Here there are three. So that's the algorithm which I was telling you about. There's a green zone, there's an orange zone, and there is a red zone. Our idea is to stay in the green zone all throughout. So what do you do? Okay, your pre-induction planning and preparation, we have just now said. So you've got a whole team with you. You've spoken to, okay, we are going in for GA. You've got all the gadgets, everything is ready nicely. Okay. So you've done your no, go back. This I need to discuss. Rapid sequence induction you will do. You will do face mask ventilation. You will do laryngoscopy, and you can't see anything. You will do one more attempt. You will do only two attempts. The third attempt has to be done by the senior most experienced anesthetist. Unfortunately, in the night, if you are working alone, then you are only the senior most anesthetist around. So there is no help around. And then what are you going to do? So two attempts maximum. Third attempt by the senior most. If you are the only one around, then third attempt by you only again. Try to get a video laryngoscope or something so that just keeping doing same thing again and again is not going to yield any different results. So your first attempt was with say a size 3 blade. You tried a size 4 blade. Nothing has happened. Change of position, ventilate, keep ventilating. Patient is getting ventilated. Fine. Up to that is fine. Third attempt with a video laryngoscope, tubes goes in. Success. Everything is hunky dory. Continue with the case. So you stayed in the green zone. Unfortunately, that doesn't happen. And now you are moving into the orange zone. And that is, you will have to announce difficult because your two attempts have missed. Your third attempt has also gone away. Now you can't keep attempting more. Ask for help, call for help, keep ventilating, whatever you have with, either with mask or with Thrive or with whatever you have, and try to put in a second generation supraglottic airway, which can be a Supreme or iGel, or whatever newer ones you have. Okay, again, here also you will try only two attempts. If you can't ventilate the patient, you are in for trouble. If you are successful, go to the yellow zone in the corner, which is mentioned. Is it essential to proceed with the surgery, safe with the surgery, or can we postpone? If it is a dire emergency, do it on an LMA, or try to put in a tube through the LMA if you have an intubating LMA and do the case. If you feel, okay, oh, well, this is not a real emergency, I can wait, then wake the patient up. The problem starts if you fail to even get LMA in, and then there is nothing. In soon, you're going to have a complete ventilation failure, or what they call it CICO, means cannot intubate, cannot oxygenate. So your patient is going to be hypoxic within no time. So now you have to do only two things. There could be a faint chance that patient has a laryngospasm. So just give a small dose of succinylcholine. I know you will feel very what you say shocked that what, how can that algorithm say already I cannot ventilate this patient and they are telling me to give succinylcholine. What is going to happen? Is going to happen is, if there is 1% chance that all this is happening because there's a laryngospasm, that laryngospasm will get relieved and your tube will go in. But at the same time, you have this risk also. But what is there to lose? You are already in deep problem. So the next step is only you have to open the trachea. So before that, if you give succinylcholine, a small dose, and try to open the laryngoscope, put in a tube of yours, what difference it makes. So when this algorithm was suggested, there was a huge uproar that they said, as it is, we can't intubate the patient and you are telling us to give succinylcholine. Then the explanation was given that, okay, it could be a laryngospasm which will get relieved. And as such, you are so much deep in problem, adding a trickle dose of succinylcholine is not going to make some huge, great difference. Anyway, the next step is to either do a cricothyrotomy or a tracheostomy and continue with the case. Next slide, please. Sachin, next one, please. Hello. Okay, so Bila, now we are going to discuss, is extubation important? Like you said, I showed you this study which was done by this American Jill Meyer, and we saw that in the later part, that is that 72 to 84 was one era when they had deaths due to failure of intubation. 85 to 2003, all anesthesia related deaths were from airway obstruction or hypoventilation taking place either in the recovery or while you are taking out the patient, that is in reversal. And this is because system error. So what do you mean by system errors? Next slide, please. That is the lapses in the setup. What do I mean by that is, say like you are an anesthesiologist who's privately practicing, you had this case and you have 4 more cases lined up. So what happens? You do this case, you reverse this case and you go away. The tube is still inside. You tell the many places there's a recovery room where they allow the nurses or the people who are observing to extubate. So there was no anesthetist, lapses in the post-op monitoring, the tube was removed. The nurse later on could not intubate. Nobody could intubate and the patients have died. And this is especially true if in a difficult intubation. So God forbid, if you have a difficult intubation and you have a busy list on that day, if you have to, first of all, either cancel the entire list and be there with this patient, because patient in the hand is most important than the next 4 patients. Secondly, medical legal issues can really crop up and take you for a ride if you're not around in a difficult intubation case. Transfer the patient to the ICU if you are in a good setup. Tell the intensivist not to extubate. Your instruction should be on the paper properly that I will come and extubate tomorrow morning. And then you go the next day, find time, extubate the patient if the patient is really properly awake. That way you will save the patient. All these problems occurred, especially in obese patients. And in America, there are Afro-Americans. They are also obese. All these are difficult intubation. The tube was removed earlier. Later on, nobody could intubate and the patients died. Next slide, please. So I'll conclude by saying and take home messages that difficult intubation in obstetrics, like I told you, is a self-invited problem. We saw why, because we are using more of regional anesthesia. Our practice of giving GA is going down. Because I am doing less, my residents also are unable to practice. And that is why their skill set is low. Such resident, when he starts practicing, you can imagine how confident will he be or she be if they want to do a GA section. These sections, obesity is increasing. So the patients are going to be obese and then they land up in general anesthesia. Emergency sections in obese is a recipe for disaster. I am again and again telling you, so plan it well, keep your setups excellent. Airway assessment is most important. So before you touch the patient, your assessment has to be proper. And then you have decided, what am I going to do? Next slide, please. Choose the place of surgery very diligently. I'm telling you again and again, the medical legal problems are on the rise because we choose wrong places to work. We work in inferior setups when there is nothing over there, no help, middle of the night, and courts are not taking this very kindly. They straight away tell you what was your compulsion to work in that setup when you knew that this patient does not have A, B, C, D, E, whatever problems they will have. And they are penalizing the anesthesiologists for conducting cases in such places. Get trained help. So have friends around. So if you are working in an inferior setup, at least call somebody who has everything, the wisdom, the knowledge. So senior person, or he's good in your work, or he has a video laryngoscope. Share the money, or ask the surgeon to pay that anesthetist separately, or if not, give all your money to that person, but get the help, because one medical legal case and your lifetime saving will be wiped off. Difficulty, again and again I'm saying, take this message that create a difficult airway cart in your place of work. I have already told you guidelines, so go with those guidelines. And then previous slide, please. Remember, there is something known as situational awareness. I want to give you the concept of situational awareness. See, many times what happens, we are in a crisis. You are working alone. I work alone in most of the hospitals. Wherever I have residents, it's fine. But many a times they are in some other OT and I am all alone. we all get fixated. Suppose now you have listened to this lecture and you have said, oh, Dr. Shinde told me obese patient in an emergency is always a problem. So it is playing in your mind. And you are extremely anxious to put your tube into the throat of the patient. Now, don't get fixated by this idea that your tube has to go in, because it is not the intubation that is going to cause problems. It is the hypoxia that is going to kill problem. So what is the situational awareness here? That what kills the patient? It's the hypoxia that kills the patient, not the tube. So even if your tube is not going in, find the ways to avoid the hypoxia and you will still be a winner, provided you have the situational awareness. So having situational awareness and not getting fixated to ideas is the most important thing. I'll give you a small example and I'll stop the lecture. There was a pilot and there was a plane. They were approaching the airport and for the landing, and the inside the cockpit suddenly alarm started coming, and it shows that the landing gear, the wheels of the aeroplane are having a problem. So continuously that alarm was flashing. So the entire cockpit crew, the co-pilot, the pilot, everybody was after it. Arey, how am I supposed to now? What is this problem? What is this problem? What is this problem? So much so that they were just encircling over the airport. Nobody was looking at the fuel. Finally, the fuel got over and the flight crashed. So the situational awareness is very important, that yes, you have a problem at hand, but you may have another major problem which you have completely missed, and the patient will go not because of primary problem, but because of the secondary. So have situational awareness, get help, choose your places wisely, create a proper difficult airway cart, and always train your staff, run algorithms, simulations, so that everybody, tell your surgeons also to help you out. Run these simulations and you will realize how many mistakes we make when the thing actually happens. And that is what my take home message to you would be, that don't lose the situational awareness. It is the hypoxia that kills. And that is how you should. I will like to say thank you to all. And then I'm ready to take whatever questions you have. Thank you very much. Thank you, Sachin.
Thank you, sir. Thank you a lot. With so much difficulties, we completed our case meet.
Yeah, no problem. That happens. Once it
Yeah.
starts going, then there is no problem.
Yeah, it will go.
Now tell me, any questions people have?
So I will exit from my screen
Yeah.
first of all.
Yeah, tell me. Any questions? I would be more than happy to answer.
So yeah. I'm just checking in question and answer box because I'm not able to even mention that thing in your lecture that we generally ask to viewers put their question and in the Q&A
No,
box.
they can
But
ask me live if they wish.
yeah. But even in chat box also they can answer. Even sometime you can raise your hand also. You
Yeah.
can ask the questions. But what you mentioned overall in your lecture, sir, that day by day that obesity is increasing and you are facing
Yeah.
almost 100, maybe below that our situation may be for difficult intubation in cesarean sections. So what you mentioned is right, sir. Day in day out, we regularly use RA for sections.
Yeah.
So nobody cares about that how airway will.
And another thing is what people and the audience must understand is, see what happens. Suppose you are working with a surgeon and you are working in a hospital, and he shows you a patient in the morning, and he tells you, "Look, Dr. Shinde, this is a patient. She has just come. Go and do the pre-op. If she lands up in section, we will do it whenever during the daytime. You are here only." Now you have seen her in the morning. At that time, she was in mild pain and say 1 centimeter dilated or 2 centimeter. But what happens is over the next 6, 7, 8 hours, the labor progresses.
Yes.
Now, with when you when she comes onto the table, you have seen her in the morning. You have seen her malampatti in the morning. This 6 to 8 hours of labor has changed her malampatti. It has again and again we have seen that what you do in the morning and then you do it after 6 to 8 hours, you will realize the malampatti 1 has become malampatti 4. There is huge edema, there is retention of fluid, the lady is tired, she is annoyed, and then when you try to do your finals, it may fail, and then you have to give a fetal distress, suddenly cord prolapse, hand prolapse, and now you are panicking. You want to give GA. She's eaten in between. You can imagine what all can go wrong. So, whatever you are doing, do your assessment of airway again, even though you have seen her in the morning. Because that 6 to 8 hours of labor can change the picture dramatically. And that is another important point you must remember, that on table assessment of any obstetric patient is very, very important.
So I remember Dr. Avinash Godke asking, can we use combi tube for difficult intubation and why it is not included in CSCV scenarios?
The combi tube, for that matter, it is again a type of an LMA. Combi tube is a type of LMA only. So obviously, a second generation LMA is used. Now I told you, it can be Supreme, it can be iGel, it can be anything. So it can be even a combi tube. If it goes in, of course it
That's
is
it.
included. It is included. A second generation supraglottic airway is of your choice. You choose. It can be a Proseal. It can be a combi tube, Proseal, Supreme, iGel, or Basca if you have that Basca mask.
Yes, yes.
It is included in the LMA, this your guidelines.
So you said in day in day out you use regional anesthesia for cesarean sections in private practice for. Uh, what type of needle you use, sir, generally? And
Okay,
this is one
I
different question.
2010 up to 2010, 2010, okay, from 1992 to 2010, that is 18 long years, I used Quinky needle, and I used to go finer and finer and finer and finer. Matlab, I started with JJ Hospital, we used to get 23. Then we moved to 25. Then in private practice, I have given with 26, 27, 29 also sometimes I have used. But 2011, I joined Hinduja Hospital, Khar. It was for 6, 7 years I was there. That time they started providing us with Whitaker needles, the pencil point ones. And then overnight I shifted to a Whitaker needle. So 18 long years or 20 years almost, I had used
Okay.
Twinkie needle of different sizes from
Numbers.
23 to 27, 28, 29. But overnight I shifted to 25 Whitaker. And that is working so beautifully that there's hardly any incidence of PDPH. It does happen even with your Whitakers also it happens, but it recovers much earlier. And the incidence between a 25 Quinky and a 25 Whitaker is very different. It is less than 1% in a Whitaker. So if you are getting and today Vitakers are very widely available everywhere. They are not very expensive, and you only need little bit of practice. And I'm sure anybody who has worked for 10 years in private practice will be easily make that switch. If I could do it in one day, like till yesterday I was using Quinky, and from tomorrow I started using uh, your Whitaker, I can, I'm very sure all of you can make it. It's the what you say, you have to make that attempt. And today I cannot live without Whitaker. Now it is so much radical thing has happened. There was a time when I was using only Quinky, and now there is a time I cannot live. If that particular hospital don't have Whitaker, matlab, I will throw a fit. I said, what are you doing? How can you live in today's times with a Quinky needle? This, that, yeah, wo. I'll eventually give spinal, but
But
I'll see to it that when I go next time, the Whitaker is available there. You make so much hours that they, and because now I'm very senior, they take me very, very seriously.
yeah, yeah,
If I make
really.
hours, they will get it. So that is how it is.
Okay.
But what
Sir,
are you all are using in your practice? What do you use it in your
Twin
practice?
K, sir. Twin K regularly 27 and 25 we are using.
Then I
Whitaker is
would
not.
suggest,
But
please use.
you mentioned about Whitaker from our city branch point of view. I will appeal to all.
Yeah, please, because it's very widely available. Tell your local distributor of any
Yes, yes, yes.
ground or
Definitely, sir. So I wanna ask about what drugs nowadays you are using for sections
okay. I
in your routine
Yeah,
practices.
routine practice is only one single thing I have been practicing. I've never changed. Like, okay, first, when I started
Yeah,
30,
yeah, yeah. Huh.
there was that time it was a different drugs. We had 5% Xylokin, which was available, which has now gone out of India. I don't see anywhere. If you are getting it, you are lucky. Otherwise, I don't see it. Then the whole world, we had 1% bupivacaine, which was called Marcaine.
Yeah,
That also went out of circulation. Then now we have 4 cc's of zero point 0.5 sensacaine, and I'm in heavy or whatever it is called. I use 0.5% sensacaine heavy. I always add fentanyl to my every spinal, whichever spinal I'm giving, whether it is for cesarean section or whether it is for any TURP or what, fracture neck, femur, whatever I'm giving. I will always add fentanyl 20 mics to my spinal anesthetic combination. The reason being not to increase the duration. Fentanyl doesn't increase the duration of the anesthesia. It gives you a dense block. It improves the quality of the block. So, in private practice, you understand this. When you are called, your every failure, you're going to lose a surgeon.
yes, yes.
So, your quality has to be top of the line. Suppose you are doing a VIP, you have given spinal, and she starts making noise. When they, most of the surgeons in Mumbai I have seen, they take out the uterus after the baby is out and then they are suturing. This is typical KEM hospital training. A lot of anesthetists, a lot of surgeons are from KEM hospital with whom I work, and they will always take out the uterus out. Now you cannot increase the sensor can part of it. That is your 2.1 or 2.2 depending upon the height of the patient. And if it's a very short patient, I'll give 2. But otherwise, 2.1 or 2.2 ml is a very, very standard dose. I always take it in a syringe and I add 20 mics of fentanyl to it. That makes the volume 2.4, but it doesn't give you any problems. There may be mild hypotension, but your ephedrine should always be ready with you. Don't allow the fall to happen. There is always co-loading going on. There was a time when we used to pre-load the patient with 1 liter of ringer lactate and all. These days, nobody does that. Everybody does co-loading. So along with the spinal only, you are giving your fluids, ringer lactate, or normal saline, whatever. So you give 2.1 or 2.2 of 0.5% bupivacaine heavy along with 20 mics of fentanyl, and that will take care of your cesarean section. in a normal height patient. If the patient is very short, 5 feet or less,
Yes,
then
yes.
I will go low. I will go 2 cc of 0.5 bupivacaine heavy. I have not tried the
So,
new drugs that
so
are available these days.
levoanamine or like that, you,
Those guys
I
keep
think,
coming and keep telling me, it is. I'll tell you something. Like I said, private practice is a result oriented business.
yes,
The
yes.
stakes are very, very high. Suppose somebody calls you even for an epidural. In the first 10 minutes, your patient should be comfortable. You do what you want, but the patient has to be comfortable. So I always have a debate with Dr. Ketan Parekh, who is a great proponent of labor analgesia. He does fantastic work. And I always tell him this, that Ketan, we are in private practice. So I always prefer CAC for my labor analgesia. As compared to Ketan, who's Britain trained, there they give conventional epidural. Now, what my defense against is that is, yes, I can give a beautiful epidural. That is not the problem. But I'm giving purposely spinal along with my epidural because look at the circumstances. Okay, you have been called. You're seeing the patient for the first time. She is seeing you for the first time. She doesn't know how great you are an anesthetist. She has no clue. She has never seen you. She doesn't trust you. She is in pain. She has suffered for almost 6, 7 hours, and now she's 4 centimeters, 5 centimeters, and she's a primey. She wants this pain to stop. You've been called. You go there, and if you give a CAC in the first 10 minutes, because CAC has a definite endpoint, you put in a needle, there's a CSF, you inject a drug in it, it acts definitely, sure shot. You went there, in the first 10 minutes, her pain has disappeared. You are God for her. You are a God for her. She will obey whatever you say to her. In the next 4, 5, 6, 7, 8 hours, you are going to be with her. The whole idea is create that confidence. You cannot create confidence by just words or by the name what your obstetrician has told you, or Dr. Shinde is very senior, he's 30 years in practice. All that will go into the basket if you don't perform well. So go there, give your CAC, make her comfortable. So I always add that fentanyl with sensacaine, heavy again, bup, 0.5. So half cc, even 0.25 cc of that, and that is quarter cc of that, and 20 mics fentanyl. I always tell her, you will get itching, but your pain will disappear. This itching is only because of the medicine which I am putting. It is temporary. It will take care of its own. You preempt them, you tell them before, and even if it happens, they are not bothered. You don't tell them and it happens, they start wondering. So always tell them what to expect, bring them on the same page, tell them that your pain is going to be less. Don't say, Array, I have come now, the pain is going to be zero. Don't say, don't over promise. If it becomes zero, she will be more than happy. But if it doesn't become zero, she's going to eat your brains. So then you say, I am here to bring your pain down from 100 to 20. So you have that leeway of 20. So even if she's getting pain, you will always say, I know you're going to get pain. I told you, I'm going to bring it down. I'm not going to take it off completely. And always use certain sentences. Like she feels pressure, she'll tell you, I'm feeling pressure. So this one sentence you should always remember. I picked this up from Ketan again. Pressure is your friend, pain is your enemy. See, these are sentences which are ready made. They create such a great confidence in the mind of the patient. They realize that he knows his stuff. He knows his stuff. And tell them exactly what is going to happen before. So when it happens, they know this man is absolutely in control of the whole situation. So you tell them itching will happen, and itching happens, she loves you. Pain will go, and pain goes, she's happy with you. You say pain will go and it doesn't go, she's going to be eating your brains. So I have also learned this over a period with doing so many of your labor analgesias. So you have to manage the surgeon also, you have to manage the patient also. So many things are you have to have. And the
Very
family.
nice. Very nice. So one thing I want to ask: how many labor anesthesias are converted into what I want to say scissor section like that?
Oh, that
How
depends.
many of your spinals are converted into GAs?
Final into GF or cesarean sections? No,
Yeah, yeah.
never, never, never. Because our surgeons are great. If my spinal has acted well, it has never failed me. But yes, if it doesn't act in the first 20 minutes, I've had such episodes also. In a year, you will always have 1 or 2, 3 years, you will always have a failed spinal. Remember, you are not here to prove anything how great you are. Okay? The whole idea is, yes, I have worked for 30 years. The obstetrician trusts me. There are times when the obstetrician is sure of my spinal and I am not. So he tells me, Are honar act, tu thamna thoda ve. And I keep telling him, No, 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 no. This is not acting. She's not even saying that I'm feeling numbness in her legs. That's chal, 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 chal. She's fasting. I'm giving GA. So he'll tell me, Are, but why are you so much in a hurry? I am telling you it will act, and it has acted also, and it has not acted also. So it goes both ways. Point is, once in a while, God gets you, brings you down to the earth. So you realize you are not, you are mortal, you're going to make mistakes. Mistakes always happen. The reason is always proximal. Remember, whenever there's a failed spinal, the reason is always proximal to the needle and not distal. So don't try to blame patient halla, patient moved, drug is inferior, unless five different anesthetists start complaining in the same hospital where you're working that their spinals are not acting, you cannot blame the drug. Always blame yourself, accept it. You've given thousands of spinals. Don't try to prove anything. Make the patient sit again if you can't give GA. Wait for 20 to 30 minutes. Ascertain how much is the action still remaining over there, because sometimes it acts partially, and then you don't want to give GA because patient is eaten something. In that case, what are you going to do? So unless and until you are sure what you want to do, don't do anything. I have one thing I have done. I have never made in 30 years, I have never made a patient sit again and give spinal again. Because long back when I had joined a hospital, I had seen a senior anesthetist. She had given, and the level went up to here. Patient, she had to intubate and send the patient to the ICU. That thing has created so much impact on my mind that I decided if I ever need to make the patient sit again and give, I will not do this. I will give general anesthesia. Thankfully, I work in good setups. Everything is available. But again, in the middle of the night, nothing is available. Yesterday night, you will not believe, yesterday night, 12:30, I was called for a cesarean section. Patient had full meal in the hospital, in the labor room at 9:30. I just lost my head yesterday. I shouted the hell out of the sisters and I said, which hospital in the world feeds the patient when you know she's a primey in labor? She can move to a cesarean section or a normal delivery. How can you feed her? So the RMO is telling me, but she was for normal delivery. I said, she was, but she can move in any way. Now suddenly the cord comes out or a hand comes out. You want me to give GA? She's had full dinner. How am I going to give her general anesthesia? So they were like looking at me as if, I have come from moon or Venus somewhere and I'm talking some strange things. So this is what happens. Thankfully, my spinal worked. I was extra careful. Even the patient was general ward and I had a resident. I said, you are not going to touch this patient. I am giving this spinal because this is not the time you are going to learn your spinals. If this doesn't act, I am in for trouble because now I have to give GA. She's eaten. And she was not 100 kilos, but she was around 85, 86 kilos. So I never wanted to give general anesthesia in a full stomach patient. I saw to it. I gave a proper Vitaker 25, 2.2 plus 20 mics fentanyl. It acted beautifully. Everything was hunky dory, and I came home. at 2 o'clock, happy that I was never needed to give general anesthesia. So, like, to answer your question, if my spinal fails, I will 100% give GA, unless I'm very sure that this is a difficult GA, patient is not fasting or some other anatomical problems. Otherwise, spinal works beautifully, no problems. And spinal going into GA is not happened because most of the surgeons finish it, and you are giving anavin with fentanyl, it will last for 2.5 hours. It's very unlikely that the section will last 2.5 hours unless there's a problem. And in that cases, then again, also I have given the, luckily, I have never had a full stomach patient, spinal not acting, and I have to give GA. That has not yet happened. I don't want it to happen again. I want
Yes,
God to be kind.
definitely. Definitely, no one should think like that, or should not happen to any anesthesiologist's life. So one person, I don't know name, anonymous person asking on this same situation. In case of high spinal ileus, I had to intubate the patient,
Yeah,
which was in emergency. Some say give bag mask for some time and tide over the crisis. But I feel very risky to give IPRR in ANC patient who is always supposed to be full
full
stomach.
stomach. Agreed.
What will you guide to manage this scenario?
No, it is better to put in your tube straight away. Put in a tube straight away. See, get help. You know, where the problem starts, I'll tell you. You've you have nobody in the OT, and then who's going to give cricoid pressure? See, the problem is who is going to give cricoid pressure? See, there's a set protocol. Now you want to give GA. You have you yourself have said every pregnant patient is a full stomach patient. So technically, you are supposed to give a cricoid pressure. One person gives cricoid pressure, another person intubates. Now you want to put in a tube. So don't even ventilate with mask. Oxygenate for 3 minutes with 10 liters of oxygen. Allow tidal oxygen to become 90, 95, 7, 900, whatever. Then give propofol. Don't ventilate. Give succinylcholine choline or whatever. Again, don't bag mask. And because you have oxygenated for 3 minutes, you will be able to put in your tube. One more thing you can do is your nasal prongs and put them on 16 liters. That is your maximum flow on a meter. 16 liters. Give a little propped up position. So what it does is the nasal oxygen that goes into nasopharynx, oropharynx, trachea, it causes something known as apnic oxygenation. Humans take oxygen and give away CO2. So at the alveolar level, there is oxygen going in and CO2 coming out. Because of that pressure difference, oxygen keeps on going, CO2 keeps on coming up. But what happens is, what you are interested in is giving oxygen. So, propped up position, 3 minutes, tidal volume, 10 liters per minute oxygen, nasal prongs, 16 liters, propofol choline, no bag masking, quick laryngoscopy. Now, the moment somebody has started injecting pentothal or propofol or whatever, there is a cricoid pressure given. Now, cricoid pressure is, or required pressure is 20 newtons. How do you decide 20 newtons? Now, that you have to practice. Now, how do you practice? Take a 20 cc syringe. Okay, I'll tell you two methods. Take a 20 cc syringe and aspirate air in it. Put it ulta on a table, and with your these two fingers, keep pushing the plunger. Okay, so because you're going to give cricoid pressure like this, so you're going to keep pressing with these two fingers and thumb. Keep pressing that. You will get that feel. Now, I cannot describe a feel on the video. So I'm telling you how to do it. Take a 20 cc syringe, empty, put air in it, put it on a table, and try practicing with your your index finger, your middle finger, and your thumb onto the plunger. that pressure that is 20 newtons. This is one method of training. So you keep training your ward boys, you keep training your nurses, you keep training your surgeons, or whosoever is going to assist you. That is the correct. And your other hand should be behind the neck of the patient, because the moment you put pressure here, there will be flexion of the neck and you will not be able to intubate. So one hand behind, other hand onto the neck, pressing with the same force of 20 newtons. Yes, that is what you should be able to do. That is one method of knowing 20 newtons. And the other method is when you put pressure onto the patient's head, or your head for that matter, and press it hard, the point at which, look in a mirror, you will realize at particular pressure, the blanching of the skin occurs. That blanching of the skin occurs at 20 newtons. So if you are doing this, look at the mirror and keep pressing your forehead. That pressure at which there is a blanching of your forehead skin, that is a 20 newtons. So these are the two methods by which you can train your staff. And that training will be helpful to you in a difficult situation. So this is kind of simulation which I am trying to tell you. See, try to run these scenarios in your nursing home, in your place of work, in your department, and you will realize how many mistakes occur. There are no clear communication that is happening. Means I do simulation workshops also, so I know how things go bad. The communication has to be very clear. Okay, the most experienced person is the one who puts in a tube. The less experienced person puts in the required pressure. So suppose you are the only anesthetist, your surgeon is going to put the required pressure. Wrongly given required pressure makes the intubation difficult. So if your intubation is becoming difficult, you realize that he is doing it wrongly. So for that moment, then tell him, okay, Baba, you remove your finger because my intubation is becoming difficult. In that case, do it without any required pressure, put your tube in. So the whole essence of my talk is that your tube should go in fast. There should be required pressure. Whether it works or no, I don't know. But there's also a lot of debates going on, because what they say is when you put cricoid pressure, your idea is to block the upper esophageal sphincter between the cricoid cartilage and the vertebral body. But they have done MRI studies where the pressure was given, the esophagus moved sideways, and it was never obstructed. So you were under a false sense of security that everything is hunky and dory, and still the patient aspirated. So required pressure, whether it works or no, there's a lot of debate going on. But medico-legally, at least you should attempt it. For that, you must train your staff. If the training is inadequate, your required pressure is not going to be adequate. Then if you're wrongly done, required pressure will make your intubation difficult. So in such circumstances, tell him to remove the finger and you intubate the patient fast. Otherwise, the aspiration is going to happen if at all the patient vomits. It's not that every patient vomits, but you cannot predict who will vomit. I have no way of telling you that this guy will vomit, this guy will not vomit. So then in that case, 2.5 pH, 25 ml of gastric volume is good enough to create aspiration pneumonitis. So that is why I said, give ranitidine, give PAN 40, reduce the acidity, and then you can intubate. So at least even if 25 ml gets aspirated, the pH will not be 2.5. So your patient will not die because of aspiration. And God forbid it happens, then send the patient to the ICU on the ventilator, symptomatic treatment, hypoxia, and that shunting becomes less over a period, higher level of antibiotics, lavage of the lungs, chest physiotherapy, that will eventually save. But it has a very high mortality. Mendelssohn is the one who invented it. And that time, out of the 65 cases, 63 died. When Mendelssohn did this study, 65 patients, 63 died. That brought his attention to the syndrome. And then he realized that this is causing, and the mortality has not come down even today. Today we take care and we don't allow the patients to aspirate. But if, God forbid, aspiration occurs, then a lot of patients still die. And that is the whole idea. The essence of this is not to allow the aspiration to occur. The aim is to prevent rather than treat. Okay. What next?
Yes, sir. Sudhir Kulkarni sir has raised her hands. Sir, you have a question? Sudhir sir, you can unmute yourself and can ask question. Meanwhile, I will continue this
Yeah.
discussion with sir.
Yeah.
Sir, you mentioned about full stomach
Yeah.
scene. I wanna know what you have in your difficult airway card. As you mentioned, you are using regularly video laryngoscope.
Yeah.
With that, you really maintain your what I can say difficult intubation card with this VL scope.
Yeah. Yeah. See, we have a cart, like I showed you the picture.
Yes, yes, same.
That cart is there. We have a fiber optic in most of the institutes also. And in bigger institutes, we have multiple video laryngoscopes. So for every ICU, there is a video laryngoscope. Every floor, there is a video laryngoscope. Every ICU has a difficult airway cart. See, these are, of course, these are bigger institutes. I am not saying
Yes, yes,
these are big institutes where,
yes.
I mean, if they have 7, 8 ICUs on different floors, you are not going to share your video laryngoscope. I have a CMAC. I don't own one, but most of the places where I go, I have requested the management to have a CMAC. So most of them have obliged. And so now I always use the D blade of a CMAC. I don't use normal blades at all because normal blades don't give you any advantage. It is the D blade, the extra curved blade of the CMAC that brings your Cormac Lehan 4 to 3 to 2, or 3 will come to 1, 4 will come to 2, and the intubations will become very easy. 1 to 2 steps down on a Cormac Lehan becomes your intubation really becomes beautiful. On top of it, you have to give a head up position, ramp position, oxygenate well. See, it's a sequence of events which you must remember. You're going to oxygenate well. You're going to plan it well. You're going to have different sizes of blades ready. But when in difficulty, or suppose I'm not doing, this is related to obstetrics. Suppose I'm not doing an obstetric case. I'm just doing a bariatric case of say 170 kilo patient. I'm going to give a ramped up position, oxygenate well for 3 minutes with 10 liters of oxygen. And then I will give propofol of whatever muscle relaxant I am using, a scoline or a, I generally don't use scoline. I use itracurium or cisatracurium, whatever I'm using depending upon the patient's condition. That I will give, and I will directly go for video larynx. I don't attempt any other because I know my first attempt of intubation is the best attempt of intubation. I don't want to try out a time, second time, then call for VL and all. No. If you have a VL, then let your first intubation be on the VL. Because ours is a generation which has done 20 years on normal laryngoscopy. And
Yes.
last 10 years, we are doing video laryngoscopy. So we are good in both. I would say a younger boy who comes today will be very well trained on video laryngoscopy. I really wonder if he doesn't get video laryngoscope outside, will he be able to do a normal laryngoscopy with a normal blade, a size 3 blade or a size 4? But that person has to practice somewhere to get this. But for all others like our generation people, we are good in both because we have worked in absolute pathetic conditions and now we are working in good conditions. We've seen nothing, hand on pulse anesthesia to the best of the monitors. We have seen video laryngoscope, we have seen single blade laryngoscopes. So we've seen everything from Twinkie needles, we've seen to Whitaker needles.
Yes.
From ether, we have seen desfluran. From for what? For twin to fentanyl. So everything we have seen, we have learned on the job. So ours is a good generation. We are So we can work in adverse condition. I don't know that the newer boys will be able to work in adverse condition, but I would say instead of them working in adverse condition, change your conditions, buy all those things, invest well, and do a case properly rather than cribbing about it. Like you said, you use Twinkie needles, and I said overnight, if I can shift after 20 years of practice on Twinkie to Whitaker, I'm sure every one of you who's listening is going to do it. It doesn't
Yes.
take much. Just make it available and start giving. क्या होगा? Initially, 2-3 may fail. उससे ज़्यादा क्या होगा? And why will that fail? Spinal doesn't change. The endpoint doesn't change. Unless the CSF comes, you don't inject. And CSF, spinal has a definite endpoint. The CSF has to come. Till that time, don't. Anything else?
I think, sir, you covered a lot on difficult airways in OBGY patients. Even you mentioned on other topics also. So we will really learn from you related to spinals and even about related to airways also. A lot of things learned from ISCC branch 100 members. So they will very much thank you, sir. On this evening of our 16th October, we are discussing our topics and doing our work. Really, I feel appreciated and very feeling happy that we are in 75 years you with you actually, and our 25th. What I am to say, silver jubilee year also.
Jubilee
So
year.
yes, yes. दुग्ध शर्करा योग आमचा पण आहे
मस्त
आणि
आहे.
आम्ही पण
जरूर. तुम्ही काय कॉन्फरन्स वगैरे केली ते काय करा, आपण करूया, येऊ ना.
येस 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 सर, डेफिनेटली डेफिनेटली करूया सर.
कारण
तुम्ही सिम्युलेशन मध्ये आहात ना सर
मी
मोस्टली?
सिम्युलेशन मध्ये आहे. आता करायला लागलो सिम्युलेशन. मी आधी नाही करायचो. आता मी
ओके.
रिसेंटली केलं. आता
हा
मी
हा हा
गंगाला माझं दुसरं आय एम डुईंग अ डिफरंट वर्क. आता मी इथे एओआरएला सिम्युलेशन
हा.
करतो. एओआरएला
चालेल
आता
चालेल चालेल.
मध्ये हळूहळू वाढवायचंय सिम्युलेशन.
येस येस येस, मी तोच विचार करतोय, सिम्युलेशन पार्ट घेऊया आपण आपल्याकडे नांदेडला. जर
त्याचा
तुमचे डेट्स.
हा नाही नाही, मला नको विचारू. मला विचारण्यापेक्षा आय टेल यू हुम. वैभवी उपाध्ये म्हणून आहे पुण्याला.
ओके ओके ओके.
मी तुला तिचा नंबर देतो.
येस येस डेफिनेटली.
तिला सांग आणि ती करते. आता ओनली प्रॉब्लेम कुठे येतो ना, ते मशिनरी लागते सिम्युलेशन साठी.
येस येस येस
ती लोक ते आणतात. मग ती त्याचे चार्जेस वगैरे सगळे तिला माहिती.
येस 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 ते ते
I will come with Vaibhavi to Nanded. That is my promise I am giving you. Whenever you call, if I am free or if I am not traveling somewhere, if I am in town, आपण ना ती ठरवूनच करूया मस्त. And
डेफिनेटली.
I'm telling you that is really helpful. There are different scenarios
हो
and
हो हो.
it takes you to the next level. आणि इतकं ते आपल्यातल्या चुका आपल्याला कळतात की
कळतात कळतात. मी तेच ते जॅनचं प्लॅन आहे माझं, नेक्स्ट मग आपण अर्लीस्ट करूया.
मी तुला वैभवीचा नंबर पाठवतो.
येस
फॅन्टॅस्टिक.
येस येस डेफिनेटली सर.
ती फक्त आता सिम्युलेशन करते. शी इज ॲट लता मंगेशकर, दीनानाथ मंगेशकर हॉस्पिटल पुण्याला आहे. शी इज व्हेरी वेल ट्रेन्ड. शी हॅज बीन ट्रेन्ड इन हाँगकाँग. शी वॉज आणि पण कुठे बँगलोरला होती. आता पुण्यामध्ये बेस्ड आहे.
हां हां.
खूप अॅनेस्थेटिस्ट आहे. आणि आता अॅनेस्थेसिया सोडून सिम्युलेशन ट्रेनिंग.
सोल्युशन पार्ट करते.
Yeah,
ओके.
complete simulation. So I would recommend definitely her name. Along with her, I will definitely come. तर
डेफिनेटली सर डेफिनेटली.
मी नंबर पाठवतो. ओके.
Yes, yes, sir. So I will concluding this session. Very, very much thank you to Hemant Shinde sir, our very lovable person from Misa News. He is the editor-in-chief, and we did a lot of work in Misa News and MSA chapter also. So I think, sir, we will meet in Borivali definitely
Yes.
on the eve of our meetings. So
Definitely.
thank you, sir. Thank you once again.
Pleasure.
Yes,
Bye.
sir.
Bye. Bye. Have a good night. Bye. 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 Bye.
Yes, sir. Bye, bye, sir. Bye.